TopMedTalk.
Well, hello and welcome to TopMedTalk. We've been in Seattle, Washington for the annual meeting of the IARS and SOCA. IARS stands for the International Anesthesia Research Society, and SOCA, the Society of Critical Care Anesthesiologists. Monty and I have been able to attend the meeting, which has been absolutely fabulous. We haven't actually sat for CME in a long time, so that's been wonderful to hear the different presentations. But of course, we're here at the meeting. We always want to seize the opportunity to be able to do what we do here at TopMedTalk, is sit down with some of the attendees, the presenters, friends of the TopMedTalk family. So today, we're lucky enough to be here sitting down with Dr. Jonathan Tan. He's Vice Chair of Analytics and Clinical Effectiveness at Children's Hospital in Los Angeles from the University of Southern California, the Keck School of Medicine. So John and I actually go a little bit back. We've known each other for several years now, working together on the Anesthesia Patient Safety Foundation group for infectious disease. So Jonathan, thank you so much for sitting down with me.
Well, thank you for having me. It's finally great to be on this podcast.
Yeah, we've been talking about it for a while.
We have been, so it's really wonderful to be here. Thank you.
That's great. Well, it was a bit of a mouthful saying all the different things that you do. I know you're involved in so many organizations. Why don't you tell us a little bit more about what you really do?
Yeah, thank you. I think I wear two different hats, but they all relate. For the first part, for the vice chair part, I'm the vice chair of analytics and clinical effectiveness. And what that means is really I oversee the strategic and operational initiatives for patient safety and quality improvement for our department, which does cover anesthesiology, critical care medicine, palliative medicine, and pain medicine. And we have a dog therapy program in our department as well.
Nice.
Yeah.
That's awesome. So you're practicing anesthesiologist. So you're in the OR in critical care?
I'm in OR as a pediatric anesthesiologist at CHLA.
Okay.
And also have this vice chair role and also a great research lab team that's working on spatial science work.
So tell us a little bit about that.
Sure. Spatial sciences is a wonderful field. It's really that intersection between geography, where people live, and the environmental and social factors that may influence them. In this particular case, our lab works exclusively with children and looking at the environmental exposures, economic exposures, neighborhood exposures as they affect pediatric health, including anesthesiology and perioperative medicine.
That's incredible. So I was going to talk to you a little bit about the organizations because this piece you presented at the meeting this year, along with some colleagues about, I guess it was the ACER and the groups, the American Society for Enhanced Recovery, and talking a little bit about this space. So why don't you tell us a little bit about your presentation, what that was about? Because I found it fascinating.
Yeah, the presentation was really about our work and the idea that we know that the environment influences so much about our health. In fact, the World Health Organization, CDC, and other organizations estimate that 80% of the health that we experience in our lifetime is social environmental exposures, social determinants of health. And so one of the barriers, though, to studying that and to understanding how factors like air quality impact children or impact us as adults is a lack of information in electronic health records. So our mission is really to partner with different organizations, bring that information into the EHR, and do some research and practical applications for patient care.
That's so interesting because whenever you were showing the images and talking about, air quality, environmental, social determinants of health, as team anesthesia, it's not something that we feel like we can control.
Right.
So talk to me a little bit about, you looking at these things and how that impacts, what we do on a daily basis and translating that into, a frontline provider.
Yeah, that's a great application question. So one of the areas that we are always focused on is there has to be a way to intervene, right? And they might not necessarily be intuitive early on, but here's a great example with air quality. If we know that kids have more likely to have an adverse event under anesthesia, laryngospasm, bronchospasm, severe coughing, hypoxia, due to smoke exposure, cigarette smoking, for example, that actually could be really similar to having a wildfire in your area. And so that risk of having a wildfire in your area may have a similar effect as having smoke exposure at home. And so we're actively studying that comparison right now with some of our work. But that being said, there are ways to intervene on a local level that we already know about. An IV induction is safer than a mask induction in those cases. It might be the case we might offer an albuterol nebulizer beforehand, which has been shown for recent URIs, for example, to reduce the risk of laryngospasm, bronchospasm as well. And so a lot of different levels and layers in which we can do some intervention to mitigate risk due to environmental exposures.
Yeah.
And of course, on top of that, there's advocacy as well that we should be doing to improve air quality as one example of the work we should be doing as healthcare professionals.
Yeah, that's incredible. So I mean, I love the idea. We're always looking for ways to identify risk really first. We have some resources, but do you think that this is going to be like the system that you're setting up is something that we can all have access to?
Yeah, that's the goal. So while a lot of the work we've done is at our hospital, we've actually done much of this work in other cities, major cities in the country. So when other hospitals, and the big vision is, want to come along, and we'll reach out to them, we have the opportunity to share air quality, other social and environmental factors with other major cities around the United States. In fact, the biggest vision that we have is to be able to have a network of health systems to have access to environmental exposure data so that they can do their own studies and also understand their population, their exposures, their risks, and possible ways to intervene locally.
During your presentation, you had some heat maps, some geography around the LA area, showing, where there was higher concentrations of, pollutants and all the, different things. Walk us through that, because we, in the world of research, talk a lot about using demographic information and looking at zip code. And that's not something that you've necessarily done, correct? Yeah, correct.
We went a little bit deeper than that. So zip codes, when we took on maps and geography, they're different levels, right?
Yeah.
At the largest level, the state, then we go to the county, then down to a zip code. And then from there, the zip codes even get smaller to census tracts and census block groups, and then the individual person. And so when we think about exposures, we want to have the smallest level of geography possible. It's the most specific. And so, for example, again, if we're looking at air quality as an example of that, if we were to look at zip code level geography for air quality, we might miss the fact that you and I live 20 miles apart from each other in Los Angeles, and yet we still get described the same air quality measure. Mm-hmm. And that's very much different than if we were being more specific, which is the work we're doing, technically more challenging, but better. We have air quality information down to 1 kilometer scale, so it's a little bit more specific to the air quality exposure that you have at your home versus where I live 20 miles away. The air quality
up in the hills versus down at the beach, or in a valley versus down in the city or something like that.
And that specificity is really important when we think about looking at exposures.
Yeah, and again, like when you showed the heat, you could just see where it was concentrated in just a very small area, and looks like about just 5 or 10 miles away that would be nice and blue and clean.
Yeah. And the exciting part is, we've known about this in public health for many decades.
Yeah.
And yet this is the first time with electronic health records, with big data, with artificial intelligence, with spatial science and spatial data science work, that we're able to actually apply this across the entire hospital system. So every single patient at scale, which is part of the magic of all of this.
Yeah, that's great. Do you see that? I mean, you're such a visionary. I mean, every time I talk to you, I'm always like, oh my God, you have amazing ideas. Do you see other applications that you could use something like this?
Yeah, I do. So air quality is just one measure. We have about 36 other measures of exposure. Some of it extends beyond the perioperative space, but I'll give a few examples within periop for a second. We have travel time and drive time distance. So when we think about scheduling our patients, when we think about considering how do we best care for patients, some of that starts just by when should we schedule them based on traffic patterns, based on where they live, especially in a really dense urban environment like Los Angeles. So we have that, for example. Other things we're looking at include temperature heat maps, UV exposure. If you're a dermatologist, you might be interested in knowing the UV exposure for kids. You might want to target certain areas in your clinics where kids live for prevention and education, and green space access as well for looking at obesity and children.
Yeah, that's great. Speaking of the green space, that just sparked a conversation that we had. I think you were telling us about a study where they were looking at the environment. Tell me a little bit about that. You know what I'm talking about?
Yeah, this is really cool.
Fascinating.
This is fascinating. So there's always been this conversation whether there's we can modify the environment, right? We go back to thinking about how can we do anything as healthcare professionals to modify things that seem to be in the neighborhood.
Yeah.
So this really great study by a former colleague of mine at the University of Pennsylvania. They received some grant funding, and long story short, they were able to purchase different plots of land in the West Philadelphia area. And there were 3 different levels of this. And in one level, they just left the vacant lot as it was in the neighborhood. Version 2 of that was they took some land and they cleaned it up. And version 3, they cleaned it up and beautified it, put some benches, new planted trees, garden, very beautiful. And across all those 3 levels, they found over time that there was an improvement in hypertension rates, improvement in obesity, improvement in well-being overall. So it's a really great study that demonstrated the value of just investing in the community and making small parks to improve health in a relatively short time frame for chronic diseases.
Yeah, that's it.
I feel like there's an intersection, right, of safety, anesthesia, perioperative, spatial, environmental exposures. It's finally starting to come together, which is the really fun part. I think that they all lived in different worlds before.
Yeah.
And so you see me kind of like in different organizations because I think there's a big push that we should converge on.
Yeah. Oh, well, it's definitely multidisciplinary.
Yeah.
And, part of the whole change management thing is bringing it all together and figuring out how to go forward and, appealing to whom you're speaking to.
I mean, I've heard you saying this over and over again, right? Change management, organizational management at the Edwards thing, right?
Yeah.
So it's totally true. I feel like it's true. We know so much already about what we should be doing.
Yeah.
We talked about this last time in the interview that we did together.
Yeah.
And yet we just have to do it.
Yeah.
And decrease variation and do the right thing.
Yeah, I know. And it's tough. I mean, it really is. But I think if we just do some mind shifting about, okay, we know all these things, like there's no reason we should have to wait 17 years or whatever the thing is that everybody quotes about adopting, whatever change it is. I think that timeline is probably protracted now, or contracted. But it still takes a long time for things. And why? Because we have all of this technology, phones, and there's no reason it should take that long.
I'll totally agree. I think we have to fundamentally change the way we think about implementation at a local level.
Yeah.
We have to do better.
And maybe that's instead of saying change management, because people get I think over it, they don't want to hear about it, but maybe it's like implementation science or we need we need branding change. That's what I always say.
We do. We do branding changes.
We need to brand some of these things in different ways. And I think that would help a lot with some things.
In our department, when we do, previously they used to be called M&Ms, right? And Thursday mornings.
Yeah.
We've changed that. So I took over patient safety for our Department of Anesthesia Care Medicine. So our Thursday morning meetings are now called patient and health system safety.
Oh.
And so it's this recognition, right, that safety is more than just the individual patient, more than just the individual team taking care of them, but it's a recognition by title, but also in reality that the system around, so supply chain.
Yes.
Right, staffing.
Yeah.
Time of day. All those things influence the outcome patient care. We still, of course, review cases, but there's a very dedicated focus thematically on not just individual patient, but how do the health system factors and team factors influence the outcome for better or worse, actually.
Yeah, yeah. If you have a chance, listen to Kevin Fong.
Okay.
The interview we did with him at WCA, absolutely incredible. He was so fantastic, and he talked a lot about are we getting risk wrong, and patient safety. We a lot of us will compare the airline industry and safety pieces to that, and compare it to anesthesia, where it's not really like that. What we're trying to do is, and what airline safety did was not that the human got better. It's that the complex system and the structure and infrastructure, all of that got better.
Yep.
And that's what we need to be focusing on. We
do. I think we look back in the last 20 years of our healthcare system, it's much more complex now. More information, more data, more people involved in the care of the individual, more technology. And we have to simplify that now that we know that there's just so much out there. Yeah. We have to simplify it for us.
Yeah. That's where I would love to see some of the research go into that. And probably I'm sure people are doing that. But we're talking a lot about AI. Yeah, I'm just I feel like we're skipping a piece kind of in the middle of it. It's how do we actually just bring all of that together? Does that make sense?
It does make sense. I think we're early stage. One of the things that I've identified, there's 3 numbers I always like to throw out there. There's 30%, there's 0 and 0. And so 30% of medical schools in the United States have an elective or some sort of offering for AI or data science, right, technology. So it's pretty low. It's elective.
Yeah.
0 is the amount of requirements for residents in graduate medical education right now, and 0 for anybody that's out there for CMEs, for requirements for AI or data science. And so until we push the needle on education and kind of pushing our whole field forward, we're going to have difficulties as a field kind of grappling and understanding complex systems using data science, AI, and information.
Well, and just technology in general.
That's right.
Integration of technology into practice. I think one of the reasons why we see so much tension and friction is that we're not putting that into, specifically teaching that.
We're not.
How to do that.
Yeah.
And that it's important. I mean, if we didn't adopt technology, we wouldn't have the pulse oximetry at this case. We wouldn't have an anesthesia machine. We would, so you kind of got to look at it over history.
We do.
Not just the fanciest stuff. It's just adopting new things into practice that can help us do it better.
We really need to partner with industry, academics, community practices, private practices across the board to do this together to advance our field.
Yeah, I totally agree. So interesting. And I just love, the stories like that when we think as team anesthesia and what we're doing in the OR. There are a lot of other things that we can do, when we're looking for advocacy. It's fantastic work you're doing. If people are interested in participating in something like this, or they have some academic interest in it, what's the best way to get a hold of you?
I think email is the best way. We can share this at the end. Otherwise, happy to hear from people for feedback. But more importantly, we have an exciting initiative we're launching in the next year ahead. We're at the point where we can expand our work and our support for different health systems across the United States. We'd love to be able to partner and create a network to be able to study social and environmental determinants of health as it impacts the operating room and outside of the OR, of course.
Yeah.
And so if they want to reach out, we'd love to partner, but definitely get on a call with them.
Yeah, that's great. And specifically peds right now, yeah? Or adults?
We could do adults too.
Okay.
Yeah. So we could do kids and adults. And we want to make sure that healthcare professionals and healthcare leaders at different systems across the United States have access to the important social and environmental determinants of health information.
Yeah, that's so cool. Before we wrap, Jonathan, I just wanted to, you're involved in a couple different organizations. I want to give you an opportunity to give a shout out to some of those and have people check them out.
Yeah, there's many great organizations in anesthesiology. Anesthesia Patient Safety Foundation is a fantastic organization that we know each other from.
Yeah.
It's been really wonderful. I have to thank the Foundation for Anesthesia Education and Research. They're just a wonderful organization,
yes.
Fair, that's been out there just promoting, pushing, not just research, but also just promoting future research, future professionals in the field. So I have to thank them for funding they've provided us. Southern California Environmental Health Science Center. Yeah. They're an environmental health group in Southern California supporting anesthesia perioperative medicine research.
That's so cool.
It's very cool. And so there are tons of organizations out there, including Society of Technology and Anesthesia as well, that I would definitely advocate people look into. Yeah. It's a great organization with a lot of leaders in technology.
And that's in STA,
STA.
Yeah, the Society of Technology, Anesthesia. That's a great place. Like if you're really interested, you're one of those early adopters, you want to hear more about what's coming down the pike as far as technology and integrating that into practice. That's a great place to see that stuff.
That's a wonderful place. And it's a special conference where not everyone's an anesthesiologist. There's a ton of engineers there, a ton of computer scientists and data scientists and industry. And we're all there together trying to advance patient care safety through technology. So it's a great conference where even the president of the society can be a PhD in engineering.
Yeah, that's right. That's very cool. Well, Jonathan, thank you so much for sitting down. I hope that we can continue the conversation. You're saying there's kind of a critical point right now in your research, and hopefully we'll hear a little bit more about that come the fall.
Yeah, that'd be great. Yeah. I'd love to update TopMedTalk in the fall and jump on any time with you, Desiree.
Yeah, awesome. Well, thanks again for taking the time out during your meeting. I know you're busy.
Having me. No, this is wonderful. Thank you for having me.
All right, and thank you for listening to TopMedTalk. You can always find us on at TopMedTalk.com on your favorite podcatcher. Also on social, we're on X, LinkedIn, Facebook. We are there. Share with your friends. That always really helps us. We also have a YouTube channel that we're kind of, just dipping our toe in the water on that. If you found us on YouTube, please give us a thumbs up. Subscribe to the TopMedTalk channel. Every little bit helps us. So thanks so much for listening. Have a great day. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.